So thank you and good afternoon. Part one is available on YouTube for viewing if you missed it or would like to see it or share it with anybody. And if you don't have that link, you can always ask me for it. Before we get started, I just wanted to quickly announce that I'm in the process of passing out our SDMH guides to who asked for one. If you did ask for one, but you'd like a printed version, they're available on our website for free online. But if you would like a printed version, just let me know and we can get that out to you. And the last thing I wanted to let you guys know about, tomorrow we are having a informative webinar, which is going to be on the topic of racism and mental health. It is directed towards CBOs and the public, and we've got some panelists coming who are going to tell us a bit about their research into the effects of racism on mental health as well as physical health. So I'm really excited for that conversation. So I just want to let you guys know that that is happening. If you'd like to attend that, I can send a link for that as well. I'll put it in the chat at some point and I'll put it in the follow-up. I'm glad to see that everybody was able to introduce yourselves and really happy to see a wide range of people here. With all that being said, I'm going to pass it over to our presenter, Kathy. Again, thank you for being here. Thank you for last time. I got I had a lot of great feedback from the last one, so I'm really excited to have you here with us again.
Thank you, thank you. So I'm trying to share, but I think I have to reclaim host role.
Oh, okay.
Or you can make me the host and then I can just share the PowerPoint or the presentation.
Okay, you should be able to now.
Yep, there we go. Okay. Awesome. Okay. So welcome everyone. My name is Kathy Grant. I am the director of the anti-violence programs for In Our Own Voices. And if you joined me last week, thank you for joining me again. This week, we're going to be talking a little bit about social justice through a community health lens and what does that mean as providers and what does that look like for our communities accessing our services. So just to kind of give an overview for folks who didn't attend last week, In Our Own Voices, we are a culturally specific organization in that we represent the community that we serve, and we work with the LGBT people of color communities. Our mission is to work for and ensure the physical, mental, spiritual, political, cultural, and the economic survival and growth of the lesbian, gay, bisexual, and transgender people of color communities. And one of the things that's great about our organization is that we do offer free direct services. With that, we offer a free food pantry that's available once to twice a month. We offer counseling services as well as case management, working with anyone who's been a victim of any type of crime and helping to navigate the criminal justice system and also navigating what does healing look like after experiencing a trauma. In addition, we have support groups, and if you want more information, please feel free to email me and I can send that information out. And then our second prong is doing training and technical assistance. So kind of what we're doing here today. We do trainings around domestic violence and its impact on LGBT communities, sexual violence, really looking at it through an anti-oppressive lens. And we do that on a local, state, and national level. And our advocacy, we sit on local, state, and national task force to really make sure that the voices of LGBT people of color are amplified and are at the forefront in creating programming. So for today, we're going to be talking about having a better understanding of oppression and its impact on clients accessing services. We'll also be able to engage in discussions on what advocacy means for them, and being able to identify solutions on creating safer, affirming, and inclusive spaces for LGBT people of color. And so one of the things that I mentioned last week, and I'll mention again, is that 2 hours is never enough to really talk about race and social justice, but this is to create a foundation. And the goal is for you to take the information and share it with your networks. So just some housekeeping items. Just make sure that you are on mute to make sure that everyone is able to hear the content. And in addition, if you have any questions or comments, and it will be interactive, please use the chat box feature, and I'll be able to, once we get to the interactive piece, I'll let folks know. And just some community guidelines to keep in mind as we go through this training today is being present as possible. Again, we live in some very unprecedented times right now. If you need to take a moment to step away to recollect yourself, or you just need a moment to step away, please do so. As Shelby said, it is recorded, so if anything, you can always come back to this. Let's see. Brave space. And so this is really important for folks to know that this is a space for learning and that we are going to make mistakes. And I ask that you feel comfortable in asking the questions, having these uncomfortable conversations, and I'll try to create as safe as a space as possible. Phase in, phase out. So for folks who are always participating in trainings, we ask that, yes, keep doing that, but also honor folks who don't necessarily always participate, and asking folks who don't usually participate to lean into that brave space and to participate today. And the biggest thing is learn in and share out. One of the things that I ask folks is if someone is giving a scenario or sharing a personal story, please don't share it without permission or consent from that individual. However, I do want you to take the items that you learned today and share it with your community and with your networks. And then making sure that we respect each other through the chat box as we go along with today's presentation. And the last one is Elmo. Everyone, let's move on. If we are getting caught up in a conversation, or if someone asks a question, I might just say, hey, I'm going to Elmo this because we're going to get to it at a later time in the presentation. So do folks have any questions, or are we all set to move on to the next one? And this is where you can use the chat feature. Okay. All right. So initially, I want to also just kind of make sure that we recap what we talked about last week. And again, Shelby has the PowerPoint from last week. So if you need it, please feel free to email her. Let's see. There we go. So the first thing that we talked about last week was the importance of language and talking about intention versus impact. That even though we might be coming from a space of causing no harm, that doesn't mean that the person who is receiving the message isn't impacted. And really being able to honor that as a community health worker, and hearing when our clients are saying like that didn't feel well, or that didn't make me feel comfortable, really being able to sit in that. Also talking about how racism manifests in subtle and overt ways. Some of the ways that we talked about that was through conversations around microaggressions and what does that look like and what are some examples of it. And also, how does racism really impact in navigating health and accessing services for communities that are most marginalized? Talking about communities of color and LGBT community of color. And also really understanding how historical trauma plays out in contemporary times. We'll be touching a little bit on this today as well, but I just wanted to make sure that folks knew kind of what we talked about last week. So to start us off, I have a video we are going to watch.
Think of a baby when it's born as a simple stick figure. Pretend identity is like the first set of clothes given to them by others who expect them to wear that throughout their life. Now consider their personal style. Might be color or hairstyle, as clothes that they would pick to best match their personality. Likewise, gender identity is shaped at birth when a doctor assigns gender. Grandparents then begin to describe boys as having strong cries or gift girls pink headbands with bows. For some, gender assignment and all that is associated with it is without conflict. As we mature, we carry this assigned identity as we engage with social structures like schools. Cisgender kids go into their assigned boys or girls bathroom without hesitation. Walking into a different bathroom is met with redirection. For transgendered and genderqueer people, however, the assignment of gender at birth is painful. Their identities create tensions and are in opposition to assigned gender roles, behaviors, and expectations from friends, family, and society. They worry, which bathroom is safe for me? This tension also happens around language. In the US, English is considered a primary or sole language, and this affects everyone's identity. Unless you're in a foreign language class or a bilingual school, there can be stigma about speaking languages other than English in the classroom or in the playground. You may receive messages that English is the only acceptable language in school. The social messaging is that speaking another language is shameful and problematic, while speaking English, ideally without an accent, is rewarded as good behavior. In this way, Spanish-speaking family members are stigmatized as others, and speaking Spanish becomes undesirable. This process explains why, regardless of country of origin, children of non-English speakers lose their language by the third generation. These are just a couple examples that demonstrate how social structures construct, limit, and place value on identities. This becomes highly problematic when school completion, racial profiling, poverty, and health disparities are associated with specific identities. Social messages from schools, peers, and the media are conflicting. They tell us that all men are created equal despite what is actually reinforced by everyday interactions. Like the classic example of a white woman who guards her purse in the elevator when a Black man enters. A clash begins when the social messaging and the actual experiences do not match. We cannot be equal if we define one group as better or even superior to another based on gender or racial identification. Whiteness is the preferred norm, the identity that all other identities are compared to or contrasted against. The norm of whiteness is so strong that it is invisible. For instance, when describing a person, if their race is not described, the assumption is that they are white. Inequality touches all parts of our lives, even when we're thinking of starting a healthy family. We assume that education, income, and healthy lifestyles should produce the same healthy birth outcomes regardless of race in the US. Yet research indicates that regardless of age, education, income, and healthy behaviors, and unrelated to genetics, Black women in the US have poorer birth outcomes than their white counterparts. Black women experience increased infant deaths, maternal deaths, and low birth rates. Many scientists associate the resulting poorer birth outcomes to increased stress related to experiences of racism. But how do we have social change and equity when those who are most affected can be demoralized and frustrated by their everyday attempts to achieve the same outcomes as their white counterparts? Our relationship to identity groups can be the key to creating change. Since social inequities occur predominantly to communities of color, social transformation requires, among other things, a mobilization of identity. Social movements based in identity, such as the Black Liberation Movement, the Chicano Movement, and the Women's Rights Movement, harness identity by educating people about social structural inequality and its impact on them. In this way, social movements can create an educated counter-narrative. Stories like that of Benjamin Banneker, a Black architect who was hired by Thomas Jefferson to build the White House after the French architect Pierre Charles L'Enfant burned down the job. This exemplifies Banneker's invisibility in U.S. history and the prominence of L'Enfant, who has a metro stop named after him in Washington, D.C. Knowing the invisible history and cultural icons of communities can be used to coalesce people with identity. It can call forth other successful historical struggles. For instance, the United Farm Workers Union and their leaders, Cesar Chavez and Dolores Huerta, carried banners of Our Lady of Guadalupe as they marched from Delano to Sacramento, California to demand justice for farm workers. The same icon was used by Father Miguel Hidalgo in Mexico's fight for independence from Spain, and again in the Mexican Revolution by Emiliano Zapata. The way that these icons were used are also evidence that global and national struggles for transformational change can be organized at local levels. As people committed to social change, the questions for us are, how much do we really understand about the history and legacies of the communities in which we work? And as both insiders and outsiders of these communities, how do we use the power of narrative informed by cultural histories of contribution, resistance, and justice to activate change in grassroots community organizing?
Okay. So this is where we engage in participation time and we use the chat box. I do have it up, Shelby, so I'm able to go through the comments. But just kind of thinking, what were some takeaways, reactions that folks had watching the video? Was there any information that stood out or information that you were like, I didn't even know that existed? And I know it's the afternoon slump, but I do encourage folks to engage in this conversation around what are things that, how does it play out in their day-to-day practice? And while I wait for folks to type their answers, I think one of the important things to think about too is that this isn't a conversation that we're just having now in 2020 with everything happening with the murder of George Floyd. This is a conversation that has been happening for decades. And so one of the things that I like to do as part of my self-care is to watch old TV shows. And one of the things that I've noticed that is bittersweet but still really sad is that we're still having the same conversations around racism being profiled by Black and brown folks being profiled by police officers. And you can see some of these examples in Family Matters, where there's 2 or 3 episodes that really talk about how racism really shows up. And we're talking about the early 90s. Same thing with Watching a Different World. And I did add at the very end in the resource section just kind of a list or an article that gives a list around talking about where some episodes that do highlight and have conversations about racism. And again, it's nothing that it hasn't been discussed before, but being able to say, okay, now how do we shift the lens to be able to move from conversation into actual practice? Okay. Data related to birth outcomes was poignant. I also picked up the assumption regarding race that if the answer is left blank, I'm checking myself to see if I do that myself. Absolutely. We don't realize, and this is the thing, is that we all are going to have biases. We're all going to have prejudice. Like, we're all going to have these assumptions that we are going to make. It's about how do we act on them, right? That's when it becomes problematic, is how we then treat each other. So thank you so much. And I think the birth outcomes is definitely something that is being talked about a little bit more, but definitely has been happening for definitely the last few years, has definitely been amplified. In addition to, one of the things that has happened as well is having Black and brown folks not believed if they are experiencing pain, because there's this idea that if you are Black or brown, that you have a higher pain tolerance or that you are seeking pain medication. And so that has impact, right? And as I mentioned last week during the training, was that Kim Porter, who was a famous Black woman, went to her doctors, let them know that she wasn't feeling well. They told her it was the common cold. A few days later, passed away as a result of having walking pneumonia. And again, it's not something that happens every so often. We continue to see this on a daily basis of symptoms not being taken seriously. And as a method of survival, you will see that there might be some folks who quote unquote will exaggerate their symptoms in order to be believed. Absolutely. So someone commented, one of the reasons why so many people of color have died from COVID is that they're not taken more seriously. Absolutely. How do I explain that I'm a whole human and not a three-fifths of a person? Absolutely. That I think, so one of my light readings that I like to do on my off time, which isn't necessarily light, is I read, and I did add it in the resource section, so no worries, is The Post-Traumatic Slave Syndrome by Dr. Joy DeGruy. And I think she really does talk and hit on this point of what you were talking about being three-fifths of a person, right? Of being seen as property versus being seen as a person. And again, we talk about, oh, slavery has been done for years. We're still seeing it in other ways, right? And so we have to have these conversations and be able to work with providers, doctors, nurses, to really be able to say, okay, let's engage in this conversation of how do we shift it from folks feeling that they're not believed or that they have to exaggerate their symptoms. How to respond when someone said to someone who says speak English. So I would say you have to reframe that in terms of what language is more comfortable for you. Ask the person that. Part of our intake form that we ask is, do they need a translator? And again, I've seen this happen as well in my own life of people asking my parents who speak Spanish and English, and my mother who her English she has a very heavy accent, so it can be a little bit difficult. And I find providers getting frustrated instead of really taking the time to say, okay, let me clarify for you. I heard you. So Shelby, I'm going to use you as an example since I'm looking at you. So Shelby, I heard that you told me that you're experiencing pain in your back. Did I get that correctly? Right? That's a shift then being able to say, can you say that in English or speak English? And we see that again. So how can we continue to have this conversation when the powers that be continue to fan the flames of racism? And I think that's an important thing too, is that, change can't really happen if we are not looking at it from all levels and if all players are not willing to make the change. And I think that's what we're seeing in this kind of revolution that's happening now, is that it's no more, oh, we're going to hire a diversity committee to address this. It's about hiring Black and Brown folks in leadership, LGBT folks in leadership, to help be a part of that decision-making table, and sometimes we don't recognize the powers that, as workers or as employees that we have. And one of the things that I encourage folks to also take a look at is there's a book by a football player, and his name is escaping me, that is about things that make white people uncomfortable. And he talks about his experience being a part of the NCAA football program and realizing how powerful but powerless he felt in navigating that and not having his voice heard, or even being molded into something that he wasn't. And so that definitely will come up and does come up. We become a community that becomes united. Exactly. And I think the biggest thing is, if we're about change, what is it really going to look like? Not just hiring one or two people of color or LGBT people of color and saying, yep, we are a diverse team, but then our policies, our practices don't mirror that either. And so I think that's super important as well. And one thing that I usually tell people is, if you're going to offer things in a different language, make sure you have staff that speak that language as well. And recognizing that even with using Spanish language, there is so many different dialects for Latinos that end up coming up, that the words do have different, what is it called? Different meanings. And so that's something else to take into account. Yes, and first getting past the false narrative that we don't see color. Absolutely. The reality is that we do. We can't walk this world because even though we think of race as a social construct, that social construct continues to play out in the different systems that we interact with, right? Of if a person of color is accessing services, there is automatically assumptions made. And it's about shifting the language from I don't see color, which can come from a well-intentioned place, but the impact of that says you don't see the additional barriers that I have to go through. You don't understand the different things that I have to encounter as being a person of color. But shifting the language to say, I treat everyone with the dignity and respect that everyone deserves, right? It's shifting that language. And what I tell people, especially during trainings, is that we're coming from a place of we have these kind of roadmaps in our brains that have been taught to us since we were born. And we're now asking you, hey, we need to switch that doesn't work anymore. That takes time. It takes time, it takes practice, it takes these conversations to be able to really start to focus on that. And one of the things that I appreciate at the end of the video is highlighting a little bit of our history that we don't talk about, right? Of how some of the history we isn't discussed, isn't educated on. And so how do we shift that as well? I definitely would recommend the podcast Criminal, and the episode is Robert Small. And that really talks about just a big part of history that isn't discussed, that I didn't even know who Robert Small was until I listened to this podcast. And the other piece that we look at is that even to find resources, it takes time. It's not like you can just walk into a Barnes and Nobles and automatically find it and it's sitting right there, right? And so we have to start shifting that and looking at where is the training going? How are we using the trainings and then putting it into practice, and not just waiting until 3 years later where there's an incident to have this training again. And so that's super important. And so with that, being able to also think about that we don't hold just one identity. One of the things that I appreciate about the video is that it talked about the variety of identities that an individual can hold, and really looking at what does it mean to live at these intersections of these different identities that we may hold, and how that can create access or continue to have systemic barriers. And so Kimberly Crenshaw came up with the idea around intersectionality, and it has definitely been developed as time has gone on in terms of the theory. But the idea is recognizing that identity markers, an example of it being woman and being Black, do not exist independently of each other, and that each informs the other, often creating a complex convergence of oppression. And it's important to recognize that, trying to get my image to come. There we go. But being able to recognize that you can't separate folks' identities, right? And what I appreciate about this statement is I can't separate my queerness from my brownness. If anything, my queerness amplifies my brownness. And so in kind of seeing that quote, I wanted to, again, encourage participation of folks' thoughts on that. And I know one of the things I may have mentioned last week is that, oftentimes I find myself going to different conferences, trainings, and at the end of the day, there will be a caucus or different, what is it called, tabletop conversations, and they'll separate it. LGBT will be in one space, Latino folks in another space. And oftentimes it becomes this place of having to choose which identity do I bring to the table, right? Or even which identity do I have to kind of show up in? And I think another part too is, do I have to tone myself, right? Tone myself down so that I can be treated with respect, and the impact of that internalized narrative that we have. And so looking at, okay, so how does oppression show up, right? What does it look like? And really looking at it that it really manifests on an individual, interpersonal, and a systemic level. And so this is where I'm going to ask folks to use their chat box to give me some examples of how does oppression show up in these different systems. Thank you, Shelby. It definitely does get challenging because it can get muddy if you talk about too many things at once. Absolutely. But I think it's important to be able to say that, when we're talking about oppression and really being able to dismantle it, we can't talk about one oppression and say, oh, we just want to end this oppression right here and think that that's enough. In order to really be anti-oppressive is really addressing it across levels. Are we going to make mistakes? Absolutely. But it's the part around, okay, what do we do with that? And how do we move forward from there? Being in the military, Black always. And I think too, also is the identities that we hold. And I think, and we see this in different policies. So within when we talk about serving in the Army, of don't ask, don't tell, and how that was reappealed, where folks who you can serve as being LGBT, but you couldn't be out about being LGBT. And so that was repealed, which was really great. But then what ended up happening is now we're seeing that got pulled back if you identify as trans being discharged from the military. And so again, our identities are being seen and not what we bring to the table. And it continues to happen in the different areas that we see. And so what are some other examples folks can think about when we're talking about institutions? And it doesn't have to be just health related. So I can open it up. So in doing some research, one of the things that I saw, education, yes. We definitely see even how we talk about Columbus Day, right? Talking about people come to the office and fill out paperwork by hand. Many do not have transportation and don't speak English. Absolutely. We make the assumption that folks can just have their own transportation or their own means of transportation, which is where I know that Department of Health really started the initiative around talking about the social determinants of health. And it's great that we talk about it, but what is the action behind it, right? To be able to really understand if someone is visibly struggling with paperwork, to be able to say, hey, do you need help with that? Being able to sit with the person instead of saying, nope, this has to get filled out or you are not going to access services. And that's definitely something that happens. Looking at it from a different perspective, also looking at who owns different sports teams, right? And how folks are being compensated for that. How many students had no Wi-Fi at home to be able to attend virtual classrooms? Absolutely. One of the examples that came up for me, which I didn't even know because I don't have children, a client was telling me, they were watching their grandchildren and they figured, oh, they can work on their computers, and they had Wi-Fi. But what they ended up sharing with me was that each household was given one computer. And so if you have more than one kid in the household, that can prove to be difficult. And so they mentioned to me, they're like, yeah, so I decided, why not use the computer that I just got? So they tried to log in, and the only way that they can get the schoolwork done was to do it from the device that was given by the school district. So again, that creates another barrier, right? Of how folks can be able to get access to education in a way that's equitable. And let's see. I know there was a comment that I missed. In church, absolutely. It's not about English. It could be a reading difficulty. Absolutely. And again, thinking about accessibility, right? It's that we make the assumptions that everyone has the same education that we've received, that the basic things or basic living activities that we were taught that everyone else knows as well. And that's an assumption, right? Because our privilege allows us to say, okay, yeah, I know how to fill out paperwork because, my parents taught me how to do that, right? That's a privilege to be able to have that. And then let me just pull up. And classism is definitely something that comes up many, many times. One of the things that I've seen on my social media was looking at what is seen as great and is applauded for when you're of a higher class versus a lower class. And one of the things that came up was language, lower income, being able to speak two languages is not necessarily applauded or seen as great. But if you're rich and you know two different languages, oh my God, that's so amazing, right? What is the difference in that? And so that definitely comes up in classes and plays out in all these very different ways. Okay. And so Shelby shared, I heard a story about a refugee family who was set up with an apartment and food, but no one explained how to use a stove. Exactly. We're making these assumptions. And when we talk about, and what we talked about last week was around equality versus equity, right? Equity is being able to say, hey, do you know how to use the stove? Do you need any help navigating this? Or even the food that we're giving you, is it useful for you? Right? Because for some people, they're like, listen, I don't know how to cook rice, but I could do the cereal and I can do pasta, right? Instead of just assuming that someone knows how to make rice or can get access to learning how to make that. And again, it's being able to ask those questions, taking a step back. And yes, is it going to take a little bit more time to explain it to someone? Absolutely. But that's part of building rapport with our communities, right? To be able to figure out what are the needs that are really out there. Part of our food pantry is we ask folks, do you have any dietary restrictions? Is there anything that we should include or not include? And for some people, they're okay with canned vegetables. For others, they're like, because of my health, I can't necessarily use canned vegetables. And it's something that I wouldn't think of because it's not something I have to think about. But I ask those questions because I need to know if I'm missing anything. Teaching in schools involve culture and class bias, as well as who is called on to answer the teacher's questions. Absolutely. And even thinking about the idea of kids who aren't participating or seem sluggish or quote unquote lazy, and again, this was on a podcast that I heard talking about, well, what they realized was that kids weren't having breakfast in their school, right? And so that became a barrier for students to be able to be fully present. And the reason why they didn't have the school, like the prepaid school lunches or the free breakfast, was because of the location, right? So assuming that because they're in a higher class area or middle class, high income neighborhood, and the school is placed there, that no one there is experiencing poverty or no one there is experiencing food insecurity. And that's something that ends up coming up. And one of the things that I appreciate about the post-traumatic slave syndrome is that Dr. Joy talks about kind of shadowing in different classrooms to kind of see how kids were kind of intaking information. And one of the things that she realized is that with white students, they were able to do a kind of a reward chart. Oh, you can get a sticker, and at the end of the week, you can get a prize, which I remember experiencing too, going to school. But what she ended up seeing was that the students of color were struggling a little bit more, that the idea of getting that sticker didn't last. But what actually ended up allowing the student to be present was that interaction of, oh my God, Johnny, thank you so much for getting this done so quickly. Let's wait for our other students to see how they're doing. And in doing that difference, she was able to see that with students of color, they were able to focus more, be more, there was more community buy-in in wanting to learn. And so again, it's these little things, these little shifts that have major impact in how people show up and access services. And so one of the things that I like about this image is that it's an example. It's not an exhaustive list, but there's examples of different types of oppression that can still come up. And the reality is that if we don't address oppression across the board, folks are still going to be oppressed. And so it has to be this conversation across the board. And one thing that someone mentioned last week, and I wanted to just make note, I did add a video around colorism, which is something that's coming up a little bit more in conversation. And this one focuses a little bit more within the Latino community. That colorism is real. It happens within communities of color of the lighter your skin is, the better treatment you get. And even growing up, and they talk about this in the video of you have to better the race, quote unquote, and thinking about the significant impact that has, right? Or being seen as not enough. And so it's not just happening within when we're talking about white folks and students and people of color, but it happens within our own communities because we're taught that the lighter you are, the better you are, the more educated you are, the more trustworthy you are. And that plays out into microaggressions. And that's been around since the Prohibition, absolutely. And we continue to still see it play out. We continue to see colorism play out in different ways. Even the way, so as a little girl, my grandmother we would watch soap operas. That was like kind of our bonding time. And one of the things that I didn't realize until I was an adult is that looking at who were the main characters and who were the servants in the soap operas, right? And so it happens in these very subtle ways that we don't think have an impact. But when we start to think about it, we say, oh, there actually isn't that many representation when we talk about soap operas or telenovelas in Spanish of Black and brown folks, right? And again, the video at the end in the resource section is definitely something I recommend because it talks about it a little bit more and also how to show up in it and how to start having these conversations. And so this is, again, interaction time. So participation is encouraged because that's what helps have these great conversations. So the question is, how do we see oppression show up in our work? Sorry, I didn't mean to show the image first. But any examples? And lack of promotion, absolutely. Being given more responsibilities, but not receiving the salary to match it is something that we end up seeing as well. Often supervisors are white, lack of credentials or a degree. Absolutely. Even thinking about when we post about, job openings, does that person have to have a master's degree? Lack of diversity in the office. Yes. Who has more of a voice during meetings? Lack of fitting into group. I wanted to say I really appreciate all the participation right now. But yes, absolutely. Who has more voice during meetings? And again, using the power to say, oh, let me step back. What are some other voices and who's sitting at the table is also super important as well. Lack of fitting into the group. Absolutely. I remember I used to work for a different community-based organization, and I remember having to kind of figure out, is it okay for me to be out as a lesbian, as a queer woman? Is it okay for me to do that? Or am I going to be treated differently? Because the Latina piece was going to come out naturally and people were going to see that. But I found myself having to censor myself, right? Or to tone myself down so that I'm not being treated differently. So absolutely. And one of the things too to kind of keep in mind of how to shift things is not just asking people of color to sit on diversity panels, but actually giving them promotions and giving them actual skills to go into positions of leadership. So the idea behind the community health workers was to be someone from the community. Now with people going to school for community health workers certification, they are now competing with the individuals from the community. Absolutely. And so thinking about what is the access there, right? How do we create it more accessible? Censoring your culture at work? Absolutely. Speaking proper English, resulting in adjusting yourself. Yep. And this is something that I've also experienced in college. And I give these personal antidotes to connect some of this information. So as a freshman, I had already been very self-conscious about my writing because, again, Spanish was my first language. And I had a professor, after I submitted my paper, asked me to see him after class. And he asked me, "Oh, is Spanish your first language? I can tell by your writing." And I remember feeling just so pushed down, and it continued throughout my college career that that was the first thought: are they going to be able to tell that Spanish was my first language and that I don't know English well enough, and having to prove myself? So absolutely, that's something that comes up. Thinking you are a client versus a staff, absolutely. That happens more often than not. Peer-to-peer services historically become professionalized services, changing the whole nature of interactions from equal to top down. Absolutely. And the thing is that, and what I tell people is that what was promising practice before, it's going to change. Even the promising practices that we talk about today are going to shift in 1 year, 2 years from now. And it's about being able to have that ongoing conversation about what does equity look like, right? And being a community health worker and working with my community, how am I bringing my community in to have the same resources or to give them the same tools so that they can advocate for themselves? And, I come from Brooklyn originally. And one of the things is, my parents are both immigrants, they're citizens, and there were a lot of services that I had no idea existed for my community until I was part of the work. And to me, it's about education, right? How do we let folks know around what are the different services that are out there? Another thing I see with organizations is the white savior complex. I'm going to finger snap to that because, yes, that does come up very, very much. And the idea is I want to help people. I want to do it for them. And that's not going to work. If you want to see change, it's about what does that person want to work on? What I tell my clients in counseling is I am like a hardware store, right? You come in, you tell me that there's a leaky faucet, and I'm going to tell you about the different options you may have. And you might say, I'm going to use Scotch tape. And I might say, okay, Scotch tape may work for now, but eventually you're going to have to replace it. It's not my place to say, no, you have to use this type of equipment. And what I tell people is that you get to decide which one works best for you, because I'm not an expert in your experience. You are, right? What I'm here to offer is different options and what is going to work best for you. Let's see. So true regarding service available. Absolutely. So one of the examples I can really give is around individuals who experience crime. I didn't know that the Office of Victim Services existed, which helps cover any financial reimbursement as a result of a crime. So if you have hospital bills, that wasn't information that I remember ever seeing up until I did the work. And so when we ask the question, why aren't people coming in through our doors? Well, is the information out there? Are we giving it to our community leaders to share that information? Is there trust in that? And you only know what you're exposed to. There's a gap from initiatives like these and the members in the community. Absolutely. And so what ends up happening is that we make assumptions of what is going to be best for the community, right? And it may be well-intentioned, but then what we realize is that that's not what the community wants, right? We make the assumptions and we apply for the funding, but then we get the funding and we're like, oh, people aren't using it. But we don't ask them why, right? And so we continue to see some of those things. So thank you. We're going to talk about this a little bit more, so please feel free to keep commenting and absolutely getting the info out to those who need the services. Yes, oh, there we go. And so some of the things that we end up seeing and how oppression shows up in the work that we do is in the image to the right, which I really do appreciate in racism, experience, and addiction and recovery, which is so true, is being taken to jail instead of detox is one of the things that I see oftentimes. Another is treats threats to your well-being viewed as controversial outside issues. The war on drugs versus the opioid crisis. And again, thinking about the roots of where that came from, right? On the war on drugs. And looking at the Rockefeller drug laws, which if you haven't ever heard of it, please do your research around it, because that was something that, you know, really was really targeted towards low income communities of color. And so that's something that we end up seeing, and it still is played out today. Look at the legalization of marijuana, right? Where you have folks who have been put in jail and are still serving time, while others are benefiting and making money off of it. Systemic factors leave Black, Indigenous, people of color, that's what BIPOC stands for, BIPOC, uninsured at higher rates, limiting treatment options. So if people don't know how to apply for insurance, they're not going to apply for insurance. If they're not going to know what is the best plan to apply for, how are they going to know? Or what treatment sources are available? Minimal representation in literature, resources, and therapists, absolutely. We have a shortage of people of color therapists in the Capital District. And again, I'm only talking about the Capital District because that's what we're focusing on today. But that has impact too. And I've had clients who have told me, you know, I've gone to other therapists who are white, and I feel like I couldn't talk about my race. I felt if they would get uncomfortable or they would just change the subject on me. And again, imagine a person who's a person of color and is also LGBT, right? To be able to talk about sexual orientation, their gender identity, and being able to not have to educate the provider, which is what oftentimes happens, versus the provider doing the education themselves and or saying, you know, let me look into this. And yes, moving from the framework of providing help, I'm the helper, to a framework of empowerment in which solving problems is a joint endeavor. Absolutely. Feeling unwelcome or disrespected in treatment and in sober living. This definitely I've seen happen many and many times, unfortunately, of folks trying to access services or who are trying to be in recovery, but don't feel safe or don't feel comfortable. Addiction is criminalized and not treated. Absolutely. Racist comments and microaggressions in recovery meetings. And that's something that we see. And it's, again, how do we start to shift these narratives? Other ways that we've seen oppression show up in work, especially with trans and gender nonconforming folks, a lot of healthcare benefits that they had before is no longer available. And this is still happening when we're talking about 2020. And so folks think that this is an idea that we've shifted from, that we're in a different place. But the reality is that these things are still happening. The racism, all the different isms that take place, even ableism as well, right? Of where are, you know, how can folks enter the building, right? Looking at how do we get our information out and not just having it in email, because not everyone has access to email, but being able to look at, are you still posting flyers? Are you doing snail mail, putting things in mail that folks can actually receive, or asking folks, what's the best way to get this information to you, right? So definitely, thank you for those examples. Some other examples that we see is food insecurity, which we talked a little bit about. And what I appreciate about this image is that folks who on payday are able to fill their house up, or even if they're receiving SNAP benefits in the beginning of the month, they're able to have enough food, but then towards the end of the month, may not have enough food to get them to the first, right? Or till their next payday. And the conversation is, well, you need to save your money better. That's not how it works. That's not how it works. And especially if you have, children or multiple people living in the household, and even ability to on choices of what to be able to buy. Someone may, instead of purchasing salads, fresh salad and vegetables, is going to purchase a packet of ramen noodles because guess what? I can get 20 of those for $2 or maybe $1. And that can last me longer than the fruits and vegetables. And cheaper food is not healthy. Absolutely. And so that's definitely something that I've seen come up of where people do want to take this, be able to have healthier food options. And the reality is that, and what I tell people is Albany has a lot of resources, but it's just very underutilized. It's very underutilized because people don't know about it. Albany Damien Center has a nutrition program. Oh my goodness, why am I losing my train of thought? The Food Capital Region Food Pantry, they do classes around being able to cook, but you wouldn't know this information. If I didn't do the work that I do around working with communities, I wouldn't know this information. And that's the problem there, is how do we move the information from just being within providers to also having it that community members know about it? And going to what someone mentioned earlier around what we've seen with COVID, is that we've had the conversation that the virus COVID-19 doesn't discriminate against anyone, and we've seen that. But the system does, right? What is the access to healthcare? Being able to apply for healthcare, access to education around being able to practice healthier behaviors. Stable housing is definitely another one as well. Looking at, homes that isn't just maybe 3 individuals living in the apartment, but you have 5 or 6 folks living in the household, and the impact of that, especially if people still need to go to work, if people still need to place their children in daycare. And so now we're seeing folks having to make this tough decision around whether or not to send their children back to school, right? And this idea of stepping away from shaming people and like, oh, you shouldn't be sending your kids to school, that's putting them at higher risk. Listen, we don't know what individual situations are, right? And so also job security, which we have seen a lot happen now, as well as food security. And someone commented, plus environmental racism is a huge factor in COVID disparities. Yes, what we ended up seeing when we saw when we were at the peak of it here in New York, looking at the areas that were most impacted, right, were areas that were heavily congested. And the thing is, looking at New York City is not a cheap place to live in. And, you have an apartment that's maybe a 1-bedroom that goes for $2,000, but expecting to be able to pay that on a minimum wage job, right? Or expecting folks to get higher education only to end up in debt. And so we have to start looking at what are the different options that we are going to be offering people as we navigate through this. And even when we have peer staff or support staff, making sure that we're paying them a wage that is actually livable, where they don't have to take 3 or 4 different jobs in order to make ends meet, because that also impacts our physical health. And another way, when the Pulse shooting happened a few years ago, we saw a major increase of LGBT folks, specifically men who have sex with men, wanting to donate blood to help the folks who were impacted and not being able to. And this is a practice that we still see. And again, I think this really resonates with me and where Andy Cohen talks about, what a loss. Here I have these robust antibodies and I can't share my plasma and possibly help anybody. So extremely disappointed. So again, we're still seeing these different levels of oppression and biases taking place. And so what is the impact? what ends up happening as a result of all these different ways that we see it happen, environmental, education, we end up seeing higher ER visits. So one example that I can give is I had a client who had recently been discharged from the hospital. They had lost their employment because they had been in the hospital for so long due to some health issues, and called me and said, Kathy, I don't have enough money to pay for my prescriptions that I need in order to help manage my health symptoms. I think I might have to go back to the ER because I can't pay for it. You know, think about having to make that choice. Think about having to make that choice now with the pandemic taking place of I rather would go to the hospital again because I can't afford my medication if I have to pay for it out of pocket. Unfortunately, we were able to help the individual pay for their medication. And that was luckily because they were connected with us. But that's definitely something we end up seeing, or not trusting their healthcare providers to be able to really see at face value that they're going to be treated. We end up seeing that our community clients are less likely to share information with us or to be truthful about what's happening, which then can lead to misdiagnosis. One of the things that we end up seeing is folks disconnecting from services or jumping from different services if their need is not met. And I'm going to put in quotations combative. A lot of times I hear, oh, this client is non-compliant. And I ask, well, what makes them non-compliant? Well, they don't want to answer the questionnaire. They don't want to do the assessment. So we can't place them into shelter. And my reaction will be like, excuse me, so they didn't answer a few questions. And for that reason, we're just not going to place them into a shelter. So they're going to sleep out on the street. Does that sound okay? And I had to end up going with the client to advocate for them because they were barred and couldn't access services for 3 months or go into a shelter for 3 months until I stepped in to be able to say, why don't we try the assessment again? Actually sit down and have a conversation, you know. And with my client who had some significant mental health issues, says, you know what, Kathy, I'm not going to say nothing. And I said, okay, that's fine. I need you to keep it cool, keep it together while we're in here. If you want to cuss or do whatever you need to do, we can do that afterwards. But I need to get you into shelter right now. And again, people get frustrated. Just like we get frustrated, our community and our clients get frustrated as well. So frequently, survival strategies that people develop to protect themselves from mistreatment are interpreted as negative traits rather than being recognized as the survival skills that they really are. Absolutely. And the thing is that you have to, and that's what it is. It's survival skills. When we're talking about communities who've been impacted by violence, trauma, we're looking at it, they're functioning from an aspect of surviving and not thriving, right? We're constantly in the mode of, I'm living day to day. Don't talk to me about what's going to happen in 10 years or in 10 months or even next week. I can't think that far ahead. I need to make sure that I have somewhere to lay my head today, not tomorrow, but today. And it's hard to be able to break from that. And what I tell folks is that that's survival skills. And then how do you shift that? How do you shift those survival skills to be in a place where you don't feel like you have to be in that at all times? And as I mentioned before, what we end up seeing as well is that when clients are seen as combative, as non-compliant, they're denied or barred access to services. So a lot of times, especially around mental health treatment, like if folks are going for mental health treatment, if a client is late for an appointment, they will not be seen, even though it might have taken them 3 buses to get to the appointment. They're not seen. They're said, oh, you have to just come to your next appointment. Or if individuals miss X amount of appointments, they have to go through the intake process again and wait. And again, what does that create for the individual? A feeling like, okay, I have to follow this straight line, or if not, my services are going to be taken away. And not realizing that life happens. We see an increase in mental health symptoms feelings of anxiety, depression. We see an increase in isolation, and especially now, since there are still not that many places open and we're offering services through telehealth. And I have my clients being able to telling me, when is the office going to be able to have clients again? And I'm like, to be honest, we have to make sure that we have the safety of everyone in mind. And for them, it's like, I don't necessarily feel comfortable doing phone sessions in my house because I feel like someone is listening to me. Or being able to leave my child alone for an hour is difficult. So again, it's about looking at it from a different perspective. And another piece that I learned a few years ago was around institutional betrayal. And it's by Jennifer Freed. And again, she's in the resource section. But she talks about it in more of around survivors of domestic and sexual violence, and feeling that there are these systems that are supposed to help them, but actually ends up doesn't show up for them, right? Or doesn't provide them the services or gives them a false narrative of what to expect. So in talking about domestic violence and sexual violence, what I oftentimes have to talk to my clients about is that it's not like Law and Order SVU where Olivia Benson comes in and fixes it in an hour, is that justice is really messed up. And how does it look like for you if it can't go through law enforcement and that person to be arrested? And so that's something that ends up coming up where people then feel betrayed. And so what I always tell people is tell your clients the process. Explain to them what are the possibilities of eligibility. What happens if they get denied? Instead of just saying, oh, you can't get these services. Let them know why. There's absolutely nothing wrong with telling the person, listen, you weren't eligible for this service because of X, Y, and Z, but let's take a look at this different resource that's available. And so with that, the question becomes, what are the systemic barriers to change? And I'm shifting the conversation for everyone who's listening today. What are some of the systemic barriers that you're seeing and being able to enact change to really combat oppression in the work that you do? Because it's not the client's identities that are creating barriers, it's the systems that we're working with. And I know that some folks mentioned earlier around the policies that are written out for clients and even staff. And I always tell people you always have to look at client policies, but you also have to look at staff policies. Are they inclusive? Higher ups using phrases like, we can't boil the ocean when wanting to bring up change. So Shelby, I'm going to ask you to explain the boiling the ocean because I haven't heard that one quite.
Yeah, no, it's just like basically like we can't do everything. We're
Right.
trying to stay in our section and do what we're trying to do. But
Mm-hmm. Lack of willingness of others to embrace change, absolutely. And I find myself when I do trainings around power and privilege, folks saying, well, I don't have privilege. I don't have privilege, or seeing it as a bad thing. And the reality is we all have it, right? And these are uncomfortable conversations that we must have in order to start really reframing and doing the work through an anti-oppressive lens, right? And so again, I've added a ton of articles at the end around talking about white supremacist culture and how we see that play out. And some examples that they give is this idea of perfectionism, right? And the problem with perfectionism is that perfect doesn't exist, right? It doesn't leave room for growth. Also, services are often based on funding requirements. So even if a provider wants to be flexible, there are operational obstacles to meeting an individual need in the way the individual will best benefit. Absolutely. So I'm not saying this, but I am saying that it's sometimes you got to find loopholes, and that's working with someone with your supervisor who's able to kind of look at it from a different lens. But even that's hard. Or getting funding 1 year for a certain amount and then getting less funding, but still expecting to do the same work, right? And still being able to provide the exact same services, the exact same financial assistance to clients, but with less money. And who does that also impact? It doesn't just impact the community, it also impacts the employees of being able to make ends meet. Increased progress in technology and agencies that requires more and more electronic savvy from clients. It makes workforce life better, but leaves folks of need behind. Absolutely. So one of the things that I've recognized is that some of my clients absolutely love the telehealth. It is the easiest thing to navigate. And so we do it that way. For other clients, they're like, nope, I don't know how to use this. I don't want to use this. So we do phone sessions. And for some other clients, texting works for them. So it's about really being able to say, okay, how can we work through this, right? What is going to be the best means for me to get you this information? You know, and I even think about it on a personal aspect of my parents. Like my mother she is technologically savvy. She knows how to text, do all this great stuff. My dad doesn't. And so I can't expect him, if I send him a text message or if I say, hey, can you read me this information so that I can do X, Y, and Z on the computer? That, you know, you're already setting that person up for failure, right? So again, being able that technology is amazing in a lot of aspects, but recognizing that it's just not for everyone, and that's okay. So absolutely. So thank you for that. What are some other examples that folks can think of in terms of systemic barriers for change? Increased progress in technology and agencies. Oh, I just read that. My apologies. So what we end up seeing is then we hear this narrative. How often do we hear the non-compliant patient narrative? Or, oh, I don't know why they won't answer my questions, or they don't pick up my phone calls. Happens quite a lot. And what we don't end up realizing is, you know, sometimes people are like, I'm not worried about, you know, filing for an emergency claim, Kathy, because I got to figure out how I'm going to pay rent today. Or, and one of the things that I've asked people, especially now, or when we were seeing people come into our spaces and for counseling, is that I would say, did you eat today? Something as simple as, did you eat today? And there were times that clients were like, oh, I actually didn't eat anything at all today. And it might be because of finances. So we talk about, hey, do you need the food pantry today? Yes, I'm a therapist and my work is around counseling, but I also need to make sure that I'm looking at it through this holistic lens and not just saying, oh, we're going to talk about your trauma today. Can't talk about trauma if I need to figure out how I'm going to pay rent. How am I going to keep my lights on or be able to have keep my phone on? And so these are conversations that do definitely need to take place. And there are definitely clients who say, you know, hey, I would love to get these services, but they operate on times when I have to go to work. And that creates another barrier. And so one of the biggest things that we're seeing that has really been really helpful for our communities is doing it. Let me back up. Is doing it from a trauma-informed lens, which this video will talk a little bit about. You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse,
violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made, plus our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
And so one additional first thing, labeling people non-compliant relieves providers of responsibility to ask what interfered with their ability to follow through and engage in active problem solving. Yes, absolutely. And then what ends up happening is that the blame is only on the client. It's not really a conversation about, okay, how do we now take a look at this? And awesome to introducing the ACEs assessments when treatment planning. ACEs assessment is a very amazing tool, and it there's a lot of studies that show that depending on scoring, what were some possible chronic illnesses that can be tied in that we end up seeing with individuals who have experienced some level of trauma and being able to talk about it. Unfortunately, in the past, I've definitely have heard folks who say, oh, substance abuse, individuals struggling with substance abuse has nothing to do with their trauma. And I'm like, excuse me? And there are folks who are doing the work. And I'm just like, we need to revision this, right? Everything is so interconnected. And when we talked about earlier around intersectionality is that our different identities impact how we show up, how we respond to the world, or how we think we need to respond to the world as well. And I know that there is a practice, I believe it's in Florida, and I think, Shelby, we were talking about this when we were talking about the training, where part of the physician's role in doing a physical or an annual physical is that they do the ACEs assessment. And what ended up happening is that they were able to actually engage in a larger conversations with clients and with families around what were the things that were maybe impacting if, there was weight gain or weight loss. If there isn't food security and you're just relying on what might be accessible at that moment has impact. You offer resources for trauma-informed care for healthcare professionals. Absolutely. I have included it at the very end. I love resources. I think that they're great. And so I definitely added, I think maybe 2 or 3 slides worth of resources. If you do find that you want more information, you can definitely send me a message and I can send some more additional things. Not every trauma results in an addiction, but every addiction is the result of a trauma. Yes, thank you for that. I'm so hopeful to find trauma-informed care trainings locally for our organization. Awesome. And what can I do, or what more can I do to help a client be compliant with what they need to do to receive the services they are requesting or that is needed? And I definitely think that in that aspect, in that scenario, asking the client, because sometimes as workers, we're more invested in the services than they are, and we have to, that's when our egos step in of, I've had a client who I needed to place that I assume needed to be in shelter, and they just would not go to DSS or the Department of Social Services. And I remember getting just so angry. I'm like, if you just did X, Y, and Z, you would be in a shelter. And then I was like, who's more invested in them being in shelter, me or the client themselves who actually needs the resource? And so when I shifted my approach of, okay, what is it that you want to do? If shelter is not an option, what is the backup? And again, being able to engage in that conversation. And so people are like, listen, when we talk even about mental health, some people, that's not something that there's still a lot of stigma around mental health, especially with communities of color. And so even that, being able to say like, well, listen, I don't talk about that stuff, so I don't need those services. And I've had clients who's come into our programming, and again, my role is primarily being the therapist, but they'll come in for maybe some emergency assistance, and it starts off with conversations of, how's everything going? Oh, last week you mentioned to me that you were having this disagreement with your partner. Where's that at now? And from that conversation, that client has been in therapy for 4 years now, really doing the work, but they wouldn't have just come in saying, oh, I'm going to come in for counseling to address my trauma. Some people may do that, but that may not happen for everyone else. And so part of trauma-informed care is also shifting our language. And I've also included some videos around differentiating gender and sexual orientation, because again, there isn't a lot of time, but I wanted to make sure that folks had access to it. So looking at even gender inclusive terms, instead of using sister or brother, use sibling. A lot of times when I've worked with survivors of domestic violence who need to be placed into shelter, I often get asked, what's her name? Making the assumption that the survivor that I'm working with is female, when that's not always the case. And I always think to myself, what if it was my client who's calling them and they receive that and they get that kind of response? And again, it may come from a place of, oh my God, I didn't even realize, but not shifting that language, just continuing to stay in that place. Instead of men and women, use everyone. Instead of wife or husband, use spouse. A lot of times when I've done trainings or even just interacting with people, and they see the ring on my finger, they'll say, oh, like, what does your husband do? And I'm like, my wife, my wife, this is what she does. Because we make assumptions off of how people look. But because I'm more feminine presenting, it almost seems impossible that I could identify within the LGBT community. And again, if clients are accessing services and they don't feel seen, they're not going to share information. They're not going to feel confident in the services that they're getting. And asking people their pronouns is also super important. And again, there's video in there to talk a little bit more about pronouns and why they're important to ask. And some people say, well, I don't want to be offensive, which is a lot of times what I hear during trainings. what I tell people who access our services, because we're LGBT POC and we're culturally specific, I tell people we don't make assumptions. You know, I'm going to ask these questions and, you know, and I'll explain it to them if I need to. So that's definitely something that comes up. Other things that we see is using person first language and looking at the examples below. Sorry, I got to plug in my computer. And for the most part, healthcare professionals do not understand the effects of trauma, as well as a non-judgmental approach to language, and that we should be using while allowing the patient to be a partner in their care. Absolutely. It becomes this idea of I know best and you need to listen to me. And what ends up happening is that folks don't, you know, aren't going to be as inclined to continue to do the work. And that's what we end up seeing, where clients are classified under the non-compliant, or they're rude, or they're, you know, they're very dismissive. And so that ends up happening. Unconditional positive regard for all humans is the approach I use. That is also called bias. Absolutely. And these things do come up. And like I said, we're all going to have them. These thoughts that we all have them, right? Our brains are automatically inclined to put things in a box. They have to fit in some sort of category. And part of it now is being able to unlearn that. And that takes time. You know, if you make a mistake, correct it and keep it moving. You know, it doesn't have to be all about, oh my God, I'm so sorry. I didn't mean to do that. You know, just say, oh, sorry. You know, John, let me see how I can better help you. And so just some additional examples. And it's difficult when you do not think in a box to redirect an organization to do the same. Absolutely. And what I tell people is, if you are able to, because at the same time, we need to keep our employment so that we can pay our bills, is challenge them a little bit to say, you know, do we have to just have male or female on our intake forms for sex? Can we add intersex? And sometimes people will say, oh, well, we can't because of funding. And the reality is that you can still add that information. You know, just because the funders aren't requesting it, you should always still have that in as part of the information of the clientele that you're working with, right? I'm not going to be apt to feel seen or to feel as if the providers know anything around my identity if I don't see it. Even looking at, and one of the things that the video brought up was around creating a welcoming space, right? You can't just have a rainbow flag if staff aren't equipped with the language to provide services and to treat and to really have an understanding of working with the LGBT community. So other ways is looking at using empathetic listening instead of dismissive listening. And so what I appreciate about this graphic is that all we do is listen. We're not trying to fix it. We don't fall into that white savior complex when we do the dismissive listening, because it's not about fixing the person in that moment. It's about being able to allow the person to share their story, you know, and that's hard. That takes a lot of courage for someone to say, I need help, especially when you're talking about communities of color who have often been told, you know, you can't ask for help. You have to figure it out on your own, or else you're going to be seen as less than. Honor your story and honor that we are all connected. Mm-hmm. And so some of the promising practices that I've written here today is really support and amplify the voices of Black, Indigenous people of color, and LGBT BIPOC. And I think that is, in the way that we talked about earlier today, was not just hiring or creating a diversity committee. And if you are going to do that, can that person be compensated for sitting on that board? Not tokenizing the one person of color who is on staff. Looking at what are the hiring practices. Again, who is taking up space in staff meetings, right? And the person who's facilitating the meeting to say, thank you so much for your input. We want to hear from other voices, right? Those are different examples of how that can look. Acknowledge your privilege and acknowledge your responsibility to fight oppression. And again, it's not just talking about one form of oppression, but really looking at it through a holistic approach, and that we are going to make mistakes, and that's okay. It's about what we do from there. And what I always say is training, training, training. You can have all the policies in place, but if you do not have training to back it up or a space for staff to be able to have these conversations, it's just going to stay there. And also having trainings that don't happen once every 3 or 4 years, but having it on a routine basis where folks are getting that information, because the reality of our field, of the health and human services field, is that there's a high turnover rate, right? And so making sure that we create that accessibility for staff coming in and staff leaving. Create and or strengthen relationships with culturally specific organizations, key community leaders, and survivors in order to better serve LGBT communities and LGBT people of color communities. And acknowledge that you have privilege, and then examine yourself regarding the degree to which you identify the attitudes and behaviors that may contribute to the re-victimization of the people with whom and for whom you work. And what I say to this is that I've included an article around how to respond when microaggression takes place, if we are the ones who do it, or if we're the ones experiencing it. And notice how oppression has changed over time and how it is subverted or resisted challenges. Study the tactics that have worked effectively against it. And thank you so much for everyone being patient and participating. Now is if anyone has any questions or comments. And if not, I will stay online like I did last week for a few more minutes. Please make sure to complete your evaluation. It allows me to know if the information I'm sharing works for folks, if there's something that needs to change. Thank you so much for, again, being present, being involved in this conversation, and participating. So thank you so much. And thank you, Shelby, for creating the space.
Yeah, I want to just to jump on that again, and thank you, Kathy, for this phenomenal presentation. I know I learned a ton, so I hope it was very helpful for everyone that's here. If you're interested in what we were talking about with the trauma-informed care and that whole aspect, I'm going to look into potentially doing that as a training for you guys. I'll start a survey and see if that's something that you guys want. And lastly, I'm just going to throw out the last reminder that tomorrow's webinar, we are going to be talking about racism as an adverse childhood experience and as a trauma in general. That's the focus of tomorrow's. It's more of it's a Q&A kind of podcast style discussion rather than like a training like this one was. But that's the kind of stuff we're going to be talking about, and we've got some people who are going to talk about their research in that. So that's it. That's everything for me. So thank you, everybody. And please fill out the evaluation form. It does help both Kathy and myself. Appreciate it. I'm going to go ahead and end the meeting then. Thank you, everyone.
Thank you. Take care, Shelby.
Bye.
Bye.